Well, good morning. Here we go for our schizophrenia lecture. It's Saturday morning. I believe it's the last lecture that has to be recorded. So let's move on here. So schizophrenia and psychosis. So just so you know, psychosis is a loss of touch with reality. Schizophrenics tend to have a loss of touch with reality. And the definition here, there are other symptoms involved with schizophrenia, which we'll see. But the prominent feature of schizophrenia is psychosis. It is a biological illness, as again most psychiatric illnesses are. It affects perception, emotion, and behavior. There are several types for the DSM-4. The DSM-5 has said there's just one type of schizophrenia, but I can assure you that physicians that have gone to medical school many years ago are still going to diagnose the different subtypes, which we will talk about. Most schizophrenics are not violent. Let me just make sure we're recording here. Yes, we are. Good. They're not violent. They usually have to hurt themselves. In fact, some of you may have seen the movie I'm Still Here, The Truth About Schizophrenia. And it shows that most patients are not apt to harm themselves, harm others, more apt to harm themselves. It is a very treatable illness, especially with the modern day antipsychotics. It's usually chronic, although psychosis does not have to be chronic. Schizophrenia is a chronic illness. Onset late adolescence or early adulthood. It's a little earlier for men. Most of these mental disorders we speak about begin in late adolescence or early adulthood. And one of the theories being with schizophrenia is that there's pruning going on, what's called nerve pruning in your brain. In other words, the brain, as it develops, gets rid of some neurons. Not always progressive, and it used to be a catch-all diagnosis where many years ago, if you went to Pilgrim State, maybe 60 or 70 years ago, or even 50 years ago, virtually everybody would have been diagnosed with schizophrenia. The DSM has refined the criteria much more clearly for schizophrenia. It is some myths here. It's not a split personality disorder. That really is called dissociative identity disorder, where someone has a separate personality. I believe there was a book called Sybil where the woman had 16 personalities. Not usually violent toward others, as I said, not caused by family dysfunction, but of course that does not help. We all would like stable households. Not caused by drug use. Of course, drugs do not help. In other words, you must have the genetics to stay in a state of constant psychosis. Akathisia is an internal restlessness, an inability to sit still. Alogia is a poverty of speech. We spoke about anhedonia, a lack of pleasure. Catatonia is decreased reactivity to your environment. The most common type we think of is a mute catatonia, where someone's in bed not moving. You talk to them, they do not respond. But other types of catatonia could be where the person is walking around, but they're just not responding to any verbal communication. You're still recording? Good. Again, psychosis is a loss of touch with reality. Not all psychosis means schizophrenia. As I think I've said before, any human being can become psychotic, put under enough stress, particularly if you're made to stay awake for, 24, 48, 72 hours a week with no sleep. All of us could become psychotic. Delusions are a fixed false belief. They can be persecutory, grandiose, referential, meaning the TV set or the radio is giving you special messages referring to you. Hallucinations can be visual, somatic, as in body, auditory, olfactory, and gustatory. Gustatory being taste. Dystonia is an impairment of muscle tone. We'll talk about that in a little bit. That's some of the side effects of the medications. Flattened affect we spoke about with depression. People with depression have a flattened affect. They don't show much emotion. Oh, neologisms. These are neo meaning new. Neologisms are made up words the schizophrenic makes up, but nobody knows what they mean except for the patient. Well, I worked in a hospital and a patient was walking around saying bougie, 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 bougie. And we said, okay, bougie, bougie, okay. Well, about 10 years ago in the classroom, a student raised their hand, a nursing student raised her hand and said, I know what that means. And my response was, you can't know what that means. That's a made up word. She goes, oh no, I know what that means. I said, what does it mean? And she said, it means give me a kiss. I said, are you kidding me? This man has just been looking for a kiss for the last 30 years. So anyway, that obviously was not a neologism. It was a word that he was saying in Polish. That's a Polish word for kiss. Okay. Tardive dyskinesia is a late onset side effect. We'll talk about this a little later. Tangentiality is when someone goes off a topic and does not return. Okay, they go off on a tangent. If you remember geometry, a tangent to the circle was the line that hit the edge of the circle and went off into space. Circumstantial means they talk around the point, talk around the question. LOA means looseness of association. Freud said that our minds work with free association. We free associate from thought to thought to thought. Maybe you see a black cat run in front of your car, and then you think of when your grandmother wore black and your grandfather died. That's free association. There's a connection there. When there's loose association, we don't see the connection, although the patient might. FOI means flight of ideas, jumping from one thought to another to another to another. So let's talk about some of the symptoms of schizophrenia. The symptoms of schizophrenia have been divided into two types, positive and negative. Let's talk about the positive. Positive symptoms of schizophrenia are symptoms that are added that you don't want, okay, such as hallucinations, delusions. Once again, a delusion is a fixed false belief. Bizarre behavior, being illogical, circumstantiality, looseness of association, flight of ideas. These are positive symptoms of schizophrenia. In other words, they're added to you, but you don't want them. On the other hand, there are negative symptoms. These are symptoms that are taken away from you that you would probably want back. Usually involve depressive symptoms such as flattened affect, decreased movements, unchanging facial and expressive movements, poor eye contact, decreased speech, anhedonia, again, a lack of pleasure, and apathy. So these are really depressive symptoms. Let's talk about some early warning signs of schizophrenia. And again, these signs have to be off the patient's baseline. We have to know the patient's baseline, and we should also know the patient's culture also, right? To view them through our culture, that could cause a distortion. Well, early warning signs, poor personal hygiene when they would usually have good hygiene, bizarre behavior, social withdrawal. As I've said in the past, human beings are highly social animals. How do I know that? We all have cell phones. So when someone was social and all of a sudden they're staying in their room, not communicating with anybody, that's a red flag something's going on. An inability to concentrate, hyper religiosity, they hang on to religion with great fervor, apathy, indifference. These are early warning signs. Again, if someone was not very social to begin with, a severe introvert, that might not be totally abnormal. This is off their baseline. Let's look at some comorbidities here. 25% of people with schizophrenia have depression. 50% have substance abuse issues. 80% smoke tobacco. Let's talk about that. Well, tobacco, actually, they have found out, helps you think a little more clearly because tobacco is a stimulant. It actually is a type of acetylcholine. When we get to the cognitive lecture, we'll learn that acetylcholine is the memory neurotransmitter. So the belief here by physicians here is that people with schizophrenia are self-medicating for their illness. They want to think more clearly. So they tend to smoke cigarettes because cigarettes clears their thinking a little bit. 50% higher rate suicide than the general population, increased incidence of cardiovascular disease and diabetes. And particularly with the newer antipsychotics, known as the atypical antipsychotics, one of the problems with them is they can cause weight gain and diabetes. Okay, the causation here. For our purposes, excess dopamine is the primary neurotransmitter involved with schizophrenia. And let's think about that. Dopamine is an excitatory neurotransmitter. Once again, you have to know the synapse and those five neurotransmitters. Dopamine is an excitatory neurotransmitter which gets you ready for fight or flight. Well, if you're involved in a fight or flight mode, you think something's about to get you. In this case, you think it's a person that's going to harm you. That would be paranoid schizophrenia. Okay. And how do we know? Um, Another way we know that the dopamine is involved here is the treatment for Parkinson's disease. We know Parkinson's is a low dopamine level. If we give somebody Sinemet, which is L-Dopa, to treat their Parkinson's disease, if you give them too much, they can become psychotic. I was working in a hospital on a med-surg unit. The patient had Parkinson's. The doctor increased his dose over the weekend and morning, Saturday morning. I came in, I gave him his increased dose. I came back an hour later to see how the patient was doing, and the patient was yelling at me and kicking at me, saying, "You're the devil, get away from me, you're the devil." Too much dopamine made him go into a psychotic state. I called up the doctor, told the doctor that the patient seems to be paranoid, and he said, "Okay, keep the dose at the regular dose. On Monday morning, I will come and readjust it." Another neurotransmitter involved here appears to be serotonin. And we know that because the atypical antipsychotics also increase serotonin. They work on the depressive symptoms of schizophrenia. General criteria for schizophrenia: some type of psychotic symptoms, delusions, hallucinations, grossly disorganized or catatonic behavior, and or some negative symptoms. And the key here is they must last for at least 6 months. So somebody can be psychotic for a couple of days, a week or two. That does not give them schizophrenia. The time threshold here is having these symptoms for 6 months or more. That's when they say you're schizophrenic. And usually, if you've had these symptoms for 6 months or more, there is a genetic basis for this illness. Again, it cannot be attributed to some other mental or physical illness. If you had brain cancer, you might appear psychotic, or you might have dementia and have some psychosis. That doesn't make you schizophrenic, though. So here are the subtypes of schizophrenia as per the DSM-4. Paranoid type of schizophrenia, psychotic or positive symptoms of paranoid type. You think people are out to get you. Minimal disorganized speech or behavior. Few, if any, affective, in other words, depressive symptoms. These patients tend to appear normal and appropriate. So you look at them and they seem to look appropriate, but in their mind, they think people are out to get them. Catatonic type, motor immobility, that's classic catatonia. The person is generally in a chair or in bed, not moving. Or you could have excessive purposeless motor activity. You're walking nonstop, bizarre posturing, bizarre grimacing, echolalia, meaning they copy what you say to them. Echopraxis means they copy what your movements. These people tend to have extreme negativism and or mutism. Another type here, disorganized type, used to be called hemiphrenic. This type of schizophrenia they tend to be aimless and disorganized. Speech and behavior is disorganized, a disheveled appearance, inappropriate affect, maybe grinning and grimacing, and silly affect, laughing at their own jokes in their head. They'll be walking around the unit kind of giggling to themselves. Psychotic symptoms are present, but not the prominent feature here. We might say this is the happy schizophrenic. They're in their own world, kind of giggling to themselves, hearing voices. So this is disorganized. Undifferentiated type is a mixed type, active psychotic positive symptoms such as hallucinations, delusions, etc. The theme of psychotic symptoms do not fit into any other type of schizophrenia. So what we're really seeing here is the DSM tries to categorize symptoms into categories, but in reality, symptoms overlap with different types of schizophrenia, and even different types of disorders. For example, we know we have psychosis in schizophrenia. Well, we could have psychosis, we could have a psychotic depression. Okay, so the DSM is trying to codify things and put them in categories, but in reality, it's very hard to put the human mind into a box. Another type here is residual type. The patient no longer has florid or very vivid psychotic symptoms. Odd behavior or beliefs continue. Negative symptoms persist, such as social isolation, lack of initiative, poor hygiene, blunted or inappropriate affect. So residual. We tend to see this when patients get older. Um, as people get older, their hormones tend to stabilize. Many patients with residual type of schizophrenia have been on antipsychotics for many, many years. So their dopamine system is kind of damped down a little bit. Residual type, residual meaning what is left. Well, let's talk about some related DSM disorders. Schizophreniform disorder, same symptoms as schizophrenia, but shorter duration. So if you have this psychosis for maybe a month or two, they would diagnose you with schizophreniform disorder. And the symptoms last from 1 to 6 months. After 6 months, the diagnosis is changed to schizophrenia. So the 6 months number is somewhat arbitrary, but I think the feeling is if you've had these symptoms for 6 months, this is a chronic condition now. And that's how it's defined in schizophrenia, chronic psychotic condition. Schizoaffective, again, schizo meaning schizophrenia, affective meaning mood. Whenever we hear the word affective, we think mood. This involves mixed mild symptoms of schizophrenia and mood disorders combined in one person. Active symptoms can be depressive or manic. So somebody can be schizoaffective, bipolar type in a depressive or manic phase. So now we have a diagnosis that incorporates schizophrenia and a mood disorder in one. Delusional disorder, non-bizarre delusion. Delusion is possible but not probable. No negative symptoms. Daily functioning may not be impaired, although social functioning may be impaired because of this delusion. So if you think someone's in love with you, but everybody else knows this person's not in love with you, but you insist they're in love with you, that becomes a problem. In fact, there was a very famous TV host, I won't mention his name, who he's off the air now. He's off TV. He retired, I believe. Who lived in Connecticut, and there was a woman who felt that he was in love with her. He just didn't know it yet. So this woman would break into his estate in Connecticut and lay on his couch waiting for him to come home. He would come home and say, "What are you doing here? You're in love with me. You just don't know it yet." Well, of course, he called the police. This happened several times. And last I heard, very, very sadly, this woman ended up committing suicide. She ended up going to jail for this because she kept breaking into his house. And, he can't have that. So last I heard, she had taken her own life. Very, very sad. Brief psychotic disorder, sudden onset of psychosis. Again, psychosis is a positive symptom. Minimal, if any, affective symptoms. Just see if we're recording here. We are. Okay. Can last 1 day to 1 month. Person returns to premorbid level of functioning, usually induced by extreme physiological or psychological stress. And that's what I talk about. And keeping somebody awake for days on end, eventually that person's going to begin to see things or believe things that are just not real. And one of the examples here is postpartum psychosis or combat psychosis. You're in combat and the bullets are flying by your head day after day after day, and you just saw your buddy who was sitting next to you, and now he's gone because a bullet hit him and killed him or whatever. That can induce psychosis. Again, it really comes down to how much can that individual take before they become depressed, anxious, or psychotic. It's an interaction between your genes and the environment. Most disorders, mental health disorders and physical disorders, are an interaction between the environment and your genetic makeup. How much can you endure? Possible causes of psychosis. Drugs of abuse. Alcohol on withdrawal, if you remember, can cause delirium tremens, also known as the DTs. Delirium is a form of psychosis. It usually goes away when we find the underlying cause. In this case, it would be coming off of alcohol. If you remember correctly, I'll remind you. How do we treat people coming off of alcohol? We give them a benzodiazepine, Ativan, Librium, Klonopin, because benzodiazepines work very, very similar to alcohol in the brain. So what we're really doing is replacing their alcohol, a GABAergic drug. GABA is the inhibitory neurotransmitter of the brain. It calms the brain down. We're replacing their GABAergic drug, alcohol, with another GABAergic drug, a benzodiazepine. Okay. Stimulants can cause psychosis also. If you remember, stimulants cause a massive release of norepinephrine, adrenaline, dopamine, and serotonin. Well, when you elevate dopamine really, really high, you can get psychosis. Hallucinogens, they affect serotonin. High levels of serotonin can cause visual hallucinations. PCP. Some people believe marijuana in very, very high doses, particularly in susceptible individuals, can cause a psychotic syndrome. So there are many ways where somebody can become psychotic. And that doesn't necessarily mean schizophrenia, though. Well, let's talk about some medications to treat schizophrenia. Another name for these antipsychotic meds they're also called neuroleptics, or a better name for them, in my opinion, is major tranquilizers. And I like the name major tranquilizers because these antipsychotic meds can also be used for anxiety and for sleep. If you tell a person you're going to give them an antipsychotic because they're anxious, they're going to say, "No way, I'm not crazy, I'm not taking that." If you say, "We're going to give you a major tranquilizer," they may accept it more readily. Okay. So the older antipsychotics, known as the typical ones, older or conventional, they predominantly bind to the dopamine D2 subtype receptor, affects predominantly positive symptoms of schizophrenia, such as hallucinations, things like that. They are good antipsychotics, but they have a lot of side effects, which we're going to look at. One of those side effects is EPS. We'll talk about that in just a few minutes. Some names here of older antipsychotics: thorazine, haloperidol, trifluoroperazine, fluphenazine, thioridazine, thiothixine, perfenazine. Note the last few letters in those medications. Like I've said in the past many times, the last couple letters in a medication indicates what class they're in. For example, most benzodiazepines end in AM. Diazepam, which is Valium, lorazepam, which is Ativan, clonazepam, which is Klonopin. So if you look at the last few letters, that can give you a good clue of what category the medications are in. Well, the atypical antipsychotics, the newer ones, and why do they call them atypical? Because they work in an atypical way. Newer antipsychotics work on both dopamine and serotonin systems. They affect both positive and negative symptoms. They have less extrapyramidal symptoms, known as EPS, and other side effects. Example here is clozapine, also known as Clozaril. This actually was the first antipsychotic. It's an excellent antipsychotic, but we'll see in a few slides that it's not first line because of its side effect profile. Another one here is risperidone, known as Risperdal, olanzapine, known as Zyprexa, geodone, quetiapine, which is Seroquel. So there are a lot of new ones, Abilify, Invega. You may see Invega advertised on TV. That is an antipsychotic. And they've noticed that these newer antipsychotics, since they affect the serotonin system also, tend to have some antidepressive properties. There are long-acting antipsychotics. One of the biggest problems with schizophrenia and many mental disorders is the patients stop taking their medicine. They feel better. They felt better for a few months. They say to themselves, "I'm cured," or maybe they don't like the side effects, and they stop taking the medicine. And that becomes a problem because now all the work we've done to get them stabilized in the hospital, the average stay in a hospital to get somebody stabilized on a medicine, the average stay is probably 3 weeks. It could go as long as 6 months, okay? Because these medicines may take a month or so to see full effect. So if it doesn't work, you have to try another medicine for another month or two. Anyway, if a patient continually stops taking their medication, what we can do is give them injectable medicine. One of these medicines is Haldol decanoate, flufenazine decanoate. There's now Risperdal Consta. These two medicines here are mixed in sesame oil. It's given as intramuscular injection, and it lasts about 28 days. The medicine slowly leaches out of the muscle, out of the sesame oil into their body. So it's a very good way to guarantee medication compliance. Long-acting medicine. Okay, I don't know why this slide does it this way. Some very serious side effects of major tranquilizers. Again, antipsychotics. NMS, known as Neuroleptic Malignant Syndrome. This is a medical emergency. This can be fatal if not treated. It is due to rapid dopamine receptor blockade. Very rare, but very serious. The signs and symptoms include muscle rigidity and dystonias, temperature greater than 130 degrees Fahrenheit, increased CPK enzymes. CPK enzymes are released when your muscles are traumatized, increased white blood cells, leukocytes, sweating, and very labile vital signs. You might remember there was another syndrome we spoke about in the mood lecture called serotonin syndrome. The symptoms of NMS and serotonin syndrome are very, very similar. Very similar. I read some psychiatrists feel it may be the same syndrome, but we got there from a different direction. What do? You hold that antipsychotic. Do not give it. You call the LIP or the prescriber, okay? And what is an LIP? I want to talk about this. A LIP is a licensed independent professional. You as an LPN are licensed. An RN is licensed. You can work independently. A physician is licensed. Some very serious side effects here. Let me just go back 1 second. So NMS is very, very serious. Here are some other serious ones. Agranulocytosis. This is a decreased white blood cell production by the bone marrow. Clozaril, as I spoke a few minutes ago, is the big one here that can cause this. Although most antipsychotics and most anti-seizure medicines can also cause a decreased production of white blood cells. Signs and symptoms: sudden onset of fever. What do white blood cells do? They fight off infection. If you can't fight off infection, you may get sick. Fever, malaise, sore throat. Again, other signs of infection. What do? You hold the medication and you call the prescriber immediately. But what you would do before you call a doctor or a nurse practitioner or a physician's assistant, you always want to take the patient's vital signs, because that's the first thing they're going to ask you. What are the patient's vital signs? So before you make that phone call, take the patient's vital signs. As I said a few seconds ago, can occur with antipsychotic and anti-seizure medicine or anti-mania drugs. But the most common one here is Clozaril. Okay. Common side effects of antipsychotics. And this is not a medical emergency. These can be treated generally. They are known as extrapyramidal symptoms, or EPS. This is due to dopamine receptor blockade also. Under this category of EPS is pseudo-Parkinsonism. Again, we know that Parkinson's disease is not enough dopamine. Well, if you block the dopamine receptor, you effectively decrease the dopamine level, okay? You cause pseudo, meaning fake, Parkinsonism. Mask-like face, stooped flaccid posture, shuffling gait, possible drooling, tremor, pill-like rolling of the fingers. Pseudo-Parkinsonism. Acute dystonic reactions, contractions of the tongue, face, neck, and eyes, Okay, they just contract and the person is breathing with these contractions. Akathisia is a restlessness. The person says they just can't sit still. They're always pacing and restless. The nurse's decision here, if someone came up and said they feel like they can't sit still, we have to decide, is this anxiety or is this akathisia? Okay. The treatment for these extrapyramidal symptoms is cogentin. Okay. But we could also, if someone had anxiety, we could also give them a benzo, which would cover some of these symptoms also. Anyway, interventions. Administer cogentin PRN. The other name for cogentin is benztropine. Okay, these are anticholinergics. Because what's happening here, what's causing these EPS symptoms is you've knocked down the dopamine level because you've blocked the receptor. But dopamine and acetylcholine are in a balance. Well, when you disturb that balance and dopamine is now lower, which effectively makes acetylcholine higher in a seesaw type balance, is you causing these symptoms. So what we have to do now is find a way to decrease the acetylcholine level. And we give cogentin, benztropine. Another one would be artane, known as trihexyphenidyl, Symmetril, which is amantadine, and Benadryl, known as diphenhydramine, can be used here also. Okay, so diphenhydramine has anticholinergic side effects. Okay, and if you remember, anticholinergic side effects are can see, can pee, can spit. You got the next word, right? Okay. So we can treat these EPS symptoms with cogentin or Benadryl, or these other medicines below. Well, here are some of these medicines in more detail. Cogentin, anticholinergic, brings down level of acetylcholine to new lower level equivalent to the dopamine level caused by dopamine receptor blockade. Benadryl does the same thing, also known as diphenhydramine. Artane, again, a piperidine, aconitin also. We can also give dopaminergics. We could possibly increase their dopamine and treat it this way. Okay? But the main medicine that I have seen used in my career was cogentin. Okay? Tardive dyskinesia. Well, tardive means late onset. Dyskinesia, kinesia means movement. So late onset movement disorder. This may not be reversible. And actually, what they feel it's due to is when you've blocked these dopamine receptors, the remaining receptors become hypersensitive to the dopamine. So you get this movement disorder. And again, it may not be reversible. Signs and symptoms include spastic, jerky, purposeless movements of the face, trunk, and limbs, lip smacking, rocking and twisting of the body and limbs. What do we do? Well, first we can apply what's called the Ames test, which I'll talk about in a second. I think some of you know about this already from the VSIMs. We can measure their tardive dyskinesia or lack of, and then treat them and apply the Ames test again and see if it's increased. Okay. But basically, we're not really using the Ames test very much anymore because the atypical, the newer antipsychotics are much, much cleaner. They don't cause EPS at that great a rate. I remember maybe 20, 30 years ago, whenever I gave Haldol or Thorazine, those are typical older antipsychotics, in that same med cup was cogentin. Okay? Nowadays, the cogentin will be given PRN if the patient shows some of these symptoms. In other words, if someone's on a newer and atypical antipsychotic, the chance of this EPS symptoms are much lower, so the doctor orders the medication as needed, PRN. Okay, the AIM scale stands for Abnormal Involuntary Movement Scale. It quantitatively assesses involuntary movements, rating them on a scale of 1 to 5. Assesses movements of the face, lips, jaw, tongue, hands, arms, legs and neck, shoulders, and hips. It's used prior to treatment, like I said, and intermittently during antipsychotic treatment to assess progression of tardive dyskinesia. But again, we're not seeing that much of tardive dyskinesia. because the atypical antipsychotics have less side effects. Well, antipsychotics also have their own anticholinergic side effects. Okay, and this is due to acetylcholine receptor blockade. So, to a small degree, these antipsychotics also bind and block the acetylcholine receptor. What do we have? We get dry mouth. What do? We can give sips of water. Some people give the patient ice chips. I don't like that intervention because we also know that patients that are on antipsychotics can have a decreased gag reflex. So that means they could choke on those ice chips more readily. So I prefer just sips of water. Urinary retention, we have to monitor voiding. If they say they can't urinate, maybe we can put them in the bathroom and turn on the water a little bit. Sometimes people, when they hear running water, they can make them urinate more easily. We can put a warm towel on their abdomen. And if none of those interventions work, well, we may have to catheterize the patient. Constipation, again, this is an anticholinergic side effect. We want to increase fluids, maybe increase fiber. Ask the LIP for a stool softener. Constipation is one of the greatest deterrents to medication compliance. Because if a patient, and it doesn't matter if these are psychiatric meds or not, any patient who gets constipated, no matter what the med, is not going to want to take that medicine. So what we want to do is make sure that patient keeps up with their normal bowel routine. Okay. So we could encourage the patient to drink lots of fluid. We could call up dietary. Let's get some more fruit on their tray. We could ask the LIP for a stool softener. Again, LIP being nurse practitioner or physician. Blurred vision. If they have blurred vision, we're going to hold the medicine and inform the prescriber. Most of these medicines cause photosensitivity, so the patient will need to wear sunglasses particularly in the summer. Sunscreen. They can cause dry eyes. We want to give artificial tears. They can cause sexual dysfunction. What can the prescriber do here? They can add Wellbutrin. Wellbutrin can also increase the sex drive. If we go back to the mood lecture, Wellbutrin, also known as bupropion, blocks the reuptake back into the presynaptic nerve of both norepinephrine and dopamine. Well, dopamine, being the pleasure neurotransmitter, is involved with the sex drive. Okay, they can also use a little blue pill known as Viagra. So there are things we can do to ameliorate, to lessen these side effects. Another side effect here is tachycardia, rapid pulse. Again, we want to assess vital signs, inform the prescribing person if the vital signs are very high. Also, they can cause orthostatic hypotension. Probably my next slide. Let's see. There we go, postural hypotension, so also known as orthostatic hypotension. So when the person gets out of bed very quickly or sits up very quickly from a chair, their blood pressure can't rise up to keep blood going to the brain and they can faint. So what do? We have the person dangle their legs on the edge of the bed for maybe, 30 seconds or a minute. We ask them, Mr. So-and-so, do you feel lightheaded? You don't feel lightheaded? Okay, let's get you into the chair. So getting up very slowly. Let's talk about causes of relapse here. Any physiological or psychological stressors, infection, pain, fatigue, insomnia, injury, breakup with a significant other, housing or work problems. Most psychiatric patients are psychiatrically fragile. What might not bother an average person may deeply disturb these clients, okay? And the biggest cause of relapse is patients not taking their meds. And this holds true for all psychiatric conditions. Remember, these conditions are genetic. We cannot cure them. It's very similar to diabetes. We cannot cure diabetes, at least not right now. They will eventually when they get to the genetic level. But as of now, these are chronic genetic illnesses that can be very well controlled. Diabetic takes their medicine and they can live a perfectly normal life. And we can use this diabetic analogy to educate patients about these disorders because most people know what diabetes is and know you need insulin. And insulin is a hormone. Hormones are similar to neurotransmitters. Nursing process here, what do we do? Well, we want to assess for symptoms of schizophrenia, as previously mentioned, observe for specific behavior, ask about drug use, because we do know that certain drugs mimic psychosis. Stimulants in very high doses, the person can become paranoid and psychotic. Hallucinogens, LSD, peyote, marijuana in very high doses. We want to ask about drug use. Alcohol withdrawal. We also want to refer to the chart of the person, the MD or the LIP who did the assessment in the emergency room. Let's see what they wrote about this. What do we want to achieve? Well, we're not doing a care plan in this class per se, but if we did a care plan, we usually want to get rid of the data that we observed originally. Okay, we want to get rid of that data. In other words, if the person is hallucinating, well, we want to get rid of that those hallucinations. When you have an outcome, all nursing interventions, or goals, I should say, need a time frame for achievement. Usually, if you look at a care plan, it'll say, what date do we expect to have this resolved? Or what day are we going to review this to see if it's been resolved? Nursing interventions, most important. This is what we do as nurses. We establish a therapeutic alliance. A therapeutic alliance basically means that the patient trusts us. Many patients think, especially if it's their first admission, that we are against them. We're not against them. Our goal is to have the patient become who they want to become so they can go and have a great life. When I worked at a hospital, there was a golf course out in front, and I used to tell the patients, look, I'd rather see you on the golf course than here, but you're not doing well, and our job is to treat you and get you well so you can go have a great life. Okay. But again, we must establish this therapeutic alliance. The patient realizes we are on their side. We are not against them. We also want to assess for suicidal ideation. That is the biggest fear in all mental health care, that a patient harms themselves or takes their own life. We also want to ask about and assess for command hallucinations. Command hallucination, the hallucination, the voice in someone's head is telling them to do something. I worked in a hospital on the 10th floor, and the voices were telling this patient, he must jump out the window. You must jump out the window. Go stand on the radiator. Jump out the window. You must jump out the window. I saw this. I was walking down the hall. I came in the room. I said, come down from the radiator. Come over here. But my voices are telling me I must jump out the window. I have to jump out the window right now. So command hallucinations are very, very serious. We can actually ask the patient, are the voices telling you to do something? Ask them, and we can ask them about suicidal ideation also. We want to assess their safety needs. We put them on maximum observation if a plan is achievable on the unit. So if someone is talking about suicide, we can put them on maximum one-to-one observation. Or if they're very unpredictable, which can be the case with manic patients in the hospital, we can do this. And then we call the provider or the physician downstairs, and we tell them what's going on. That doctor will come up, assess the patient, and will either write an order for special observation or say it's not needed. But we have done our due diligence. We did our job by informing the clinician of the patient's symptoms. We want to provide a calming, non-threatening environment. We talk to the patient in a calm, clear tone that leaves minimal room for misrepresentation. Okay. People that have psychosis can get a different message than we mean. So we have to be very clear that we're not saying things that can be misinterpreted, particularly sexual things and things like that. Do not confront delusions directly. We instill gentle doubt. For example, if a person says, I'm president of the United States, we might respond by saying it would be unusual for America to have two presidents. In other words, we're not saying that they're wrong. They truly, truly believe this. If you tell them that they're wrong, they may get very angry. It would be somewhat equivalent to me telling you that your name is not your name. Your name is Mike. No, it's not. Yes, it is. No, it's not. Patient can get upset because they believe these delusions. Okay. So again, we instill gentle doubt. We do not confront the psychosis directly. Patients do not have to defend their thoughts. We avoid asking why. When you ask a patient, why do you feel this way? Why do you do this? Why do you think this way? You're asking a patient to defend their mental illness. We don't want to do that. Okay. They don't have to defend why they're ill. If they knew why they're ill, they might not be ill, actually. We want to focus on feelings that the delusions may create. If a delusion is saying that they're a loser or that they're a bad person, we could say, yes, I could see how that would be upsetting to you. Or maybe they think that the food is poison, Mr. So-and-so. I could imagine it must be scary thinking that food is poisoned or people are out to get you. So we focus on the feelings that the delusions may create. We could use distraction techniques to take the patient's mind off these delusions, listening to music, TV, card playing, or simple conversation. And as I've said to some of the clinical students, I'll have all of you eventually, you know, out of every hour, you should try to carve out 10 or 15 minutes where you go out on that floor and just be with the patients. Just sit with them. It shows them that you like them. It shows them that they're worth your time. And also, you get to assess them. Now, there are nurses' aides that are out and about the unit, but we want to have direct contact with the patients. So my feeling is you should be out on that unit at least 10 or 15 minutes of every hour, just talking to the patients yourself. How are you doing, Mr. So-and-so? How are you feeling today? Do you feel a little better than last week? It shows concern. It shows that we care about them. You may have to provide ADLs if patient cannot. If someone's very, very psychotic, or for that matter, very, very depressed, they might not be able to feed themselves, bathe themselves, groom themselves. Okay? We administer meds as prescribed. And again, we may have to limit set if they're going to other patients' rooms. Mr. So-and-so, I'm asking you, please don't go to other patients' rooms. That's inappropriate behavior. We never use the word bad or things like that. Inappropriate. Chronic phase, or the phase of discharge from the hospital. But let me say that I have heard that schizophrenia is a disorder of thirds. A third of the people can be treated and you will see no symptoms, provided they stay on their medication. They can become doctors, nurses, teachers. Another third can do quite well, but has exacerbations and it comes back, and then it goes into remission, then it comes back. And about another third, we just can't seem to get them squared away. But I can say, as the medicines have become better, we are able to treat more patients effectively. So when the patient leaves the hospital, they should have an established daily structured schedule. They should know where they're going, where they're going to live, transportation to and from their doctor's visits. Okay. We should outline LIP visits and other appointments on a calendar for the patient. Usually, if someone is very ill with schizophrenia, they will have a case manager or a family member that tends to care for them. And we want to educate the family member about this also. Okay. Make sure a patient has housing and transportations figured out. All of us like structured routine. When we're out of our routine, we tend to get anxious. And as I've said before, this is the problem with COVID. COVID has disrupted all of our activities. Where you guys are learning at home. I'm recording these lectures. We're not in a routine yet, although we're getting there after 5 months of COVID. We're establishing a new routine. But a few months back, people were very anxious because they didn't know where this was going, and their routine was disrupted. When you're anxious and out of your routine, you release more dopamine, okay, fight or flight, and that can make psychosis worse. Okay. So the patient, when they're discharged from the hospital, should have very good discharge plans. They should know where they're going, what the housing is, transportation, things like that. We want to educate patient, family, significant others about med compliance, which is the most important piece here, times of med, and potential side effects. We also want to educate the patient and family members, significant others, about early signs of relapse. In other words, exacerbation of symptoms, such as self-isolation, anhedonia, increased delusions or paranoia, decreased hygiene, and again, other acute signs and symptoms of schizophrenia. Okay. We emphasize patients should not stop the med on their own. They must consult their physician. Very important. They used to give drug holidays many, many years ago, maybe 50 or 60 years ago. They would take the patients off their medication, maybe Haldol, to see if they were better without the medicine. And they have found, as a general rule, that does not work. Also, that medicine may not work again. This can also happen with antidepressants. When patients go on and off these medicines or antidepressants, those medicines are less effective over time. So you're losing a tool in your toolbox for treatment. If patient stops on own for a long period of time, LIP has to start all over again in stabilizing the patient. And again, getting someone stabilized from depression, bipolar, or schizophrenia can possibly take several months because one medicine doesn't work. We try another one for a month. That doesn't work. We try another one for a month. So med compliance is of utmost importance. And that is the nurse's domain. We educate the patient the importance of staying on their meds. If they don't like the side effects, they have to talk to the prescriber. Conclusion. Although schizophrenia is a serious mental disorder, it is becoming very, very treatable. New meds are coming out every year, new meds come out. Our job is to offer support and hope. What's going to happen in the future is medications, the new frontier is going to be on the genetic level. What's going to happen is they're going to identify the genes. Schizophrenia is probably not one gene. They're going to identify the genes that are not working properly, find a way to give the person a functioning gene to replace the gene that's not functioning, and then we will have truly cured the disorder. And this is going on with cancer also, because cancer is also genetic. Your cells are not multiplying in an orderly fashion. So we have to find the DNA that's not working, and they will fix that DNA. Okay. Well, I want to say thank you. I'll be posting this lecture in about an hour or so on YouTube. And please keep studying hard. Do your VSIMs, do your Prep U. If you're doing those assignments earnestly and sincerely, you should be fine in the upcoming test. Thank you so much.